Okay. Hi, everyone. Today we'll be talking about anorexia nervosa and bulimia nervosa. I'm Adriana.
I'm Amelia.
I'm Emma.
I'm Himija.
And I'm Luca.
So to start off, I'll be talking about a little bit about the overview of the DSM-5. And the DSM-5 is essentially the Diagnostic and Statistical Manual of Mental Disorders, and it is published by the American Psychiatric Association, and it is a standardized system that clinicians use to identify and classify mental disorders. It helps provide clear definitions, symptom criteria, and descriptions for a wide range of conditions. And many psychiatrists, psychologists, and other healthcare providers rely on it to help guide diagnosis and treatment planning. And the DSM also helps create a shared language across the mental health field, which helps improve communication, research, and access to services across the field. And overall, the DSM-5 plays an important role in helping providers better understand mental disorders and deliver more consistent care. And now to go over some of the strengths of the DSM-5. One major strength is that it gives clinicians a standardized language. This helps reduce confusion across the field and helps make communication more accurate across different providers, hospitals, and systems. Additionally, it also helps provide comprehensive summaries of mental disorders. It often includes symptom patterns, risk factors, prevalence information, and cultural considerations, which help clinicians understand the full picture of a disorder so that they can rely on a standardized framework instead of experience or guesswork. And another strength is that it improves diagnostic consistency. This structure criteria helps clinicians make more reliable diagnoses even when symptoms overlap with other conditions. And lastly, the DSM-5 also supports treatment planning because the criteria are so detailed. They help providers match patients with the right interventions and evidence-based care.
I'll be going over some of the weaknesses of the DSM-5, and one of the biggest weaknesses is the risk of overdiagnosis. The DSM-5 includes a extensive list of symptoms, and clinicians may diagnose too readily when symptoms overlap or appear similar across disorders without going through and making sure that to differentiate between the two. There's a lot of cultural bias and stigma within this manual. Um, these manuals are all written from a Western perspective to medicine and can neglect the influences of race, culture, and ethnicity. So clinicians have to ensure that they're being more conscious of medical conditions, psychological factors, and social contexts when considering the diagnostic framework. And then something that has been pretty criticized within the DSM-5 is the removal of the multi-axial system. Um, they believe that this system provided a more holistic approach to diagnosing mental disorders, and its removal has been criticized. And the DSM-5 really ignores the underlying conditions and social influences, which the multi-axial system included. And the next, we're going to compare the DSM-5 to all the previous versions. I'm actually going to start all the way at the DSM-1. This was the first major attempt to standardize psychiatric diagnosis, and it was heavily subjective and very broad. We considered the DSM-1 psychoanalytic, and as we moved to the DSM-2, it was also considered psychoanalytic. However, it did increase the number of disorders and in slightly more descriptive approach to these disorders. Also included some slightly controversial disorders in today's age, including homosexuality. As we move to the DSM-3, we kind of shift from the psychoanalytic and Freudian thought to a more descriptive and observational approach. So this looks like explicit diagnostic criteria, and we added in the multi-axial system, which was a little more of a holistic approach. As we kind of move to the DSM-4, this is where we begin seeing a more evidence-based system. So there was systemic evidence-based revisions, and then there's also large-scale literature to make informed changes. The multi-axial system began at this point to be seen a little bit as artificial and started to be criticized, and it did not include dimensional models. And then as we move to our current version, the DSM-5, this was it's kind of a hybrid of a categorical and dimensional approach. So we removed the multi-axial system, which was seen as artificial. We created a new dimensional model for categorization of disorders. We included new disorders, including binge eating disorder. Um, this was kind of when we began thinking about being more culturally informed within this manual, and it was a slightly more flexible and spectrum oriented.
So I'm going to be talking about the overview of anorexia nervosa. So anorexia nervosa includes two components, which is the behavioral components, which include severe restriction of taking in food, and then cognitive distortions, which these individuals have a fear of gaining any weight, and also a distorted body image. So the DSM-5 defines anorexia nervosa as significantly low body weight based on age, sex, developmental trajectory, and physical health, rather than using a strict numerical cutoff, which means that these individuals may not recognize the severeness of their low body weight, which contributes them to not getting any treatment or treatment resistance. And there's also some physiological features, which includes intense fear and worry about gaining weight, distorted self-perception of their shape and size, and denying the seriousness of their condition. Um, the DSM-5 continued about anorexia nervosa. There's two types, which is restricting type, which they lose weight due to dieting, not eating, or excessive exercise. And also the second one is binge eating purging type, which there's periods of binge eating or purging, which they vomit after eating. They take laxatives before they eat, so it just goes straight through them and no digestion of the food happens. And also, binge eating occurs when the person is at extremely low body weight, which is very detrimental to their health. And also, the DSM-5 removed the requirement for anorexia, which is the absence of at least three consecutive menstrual cycles, which this is a significant shift from the DSM-4. This change was made because many individuals with anorexia, including children, adolescents, males, and post-menstrual individuals, do not menstruate, making the criterion gender biased and developmentally inappropriate. Some individuals who meet all other criteria may still menstruate due to hormonal variability, which would be excluded from the diagnosis under earlier editions from the DSM. So the DSM overview of bulimia nervosa. So bulimia nervosa is defined by cycles of binge eating and compensatory behaviors designed to prevent weight gain. So most individuals with this disorder maintain a body weight that is within the normal range or above, which makes the disorder less visible and harder to diagnose. So these episodes of binge eating involve eating objectively large amount of food in a discrete period within 2 hours. And they also have a sense of lack of control over eating during the episode, so they feel unable to stop or limit the amount that they eat. And then these individuals have some compensatory behaviors, which include self-induced vomiting, misuse of laxatives, fasting or skipping meals, and excessive exercise. So continued with bulimia. Some clinical considerations include people with bulimia often appear medically stable, so it can go unnoticed. And they include some emotions of shame and secrecy that may stop them from seeking help or treatment. And then bulimia can cause major medical issues, including electrolyte imbalances, heart complications, gastrointestinal damage, like throat and stomach and esophageal issues. Okay, and then some treatment strategies for both anorexia and bulimia. Um, so these include finding the right type of eating disorder treatment depending on their disorder and symptoms. So it can really vary from each disorder, and it usually includes a mix of specific types of therapy like talk therapy, psychotherapy, as well as monitoring nutrition and medical and educational advice. And some medications include some reuptake inhibitors, and this is seen to be effective for bulimia, but very limited impact treatment for anorexia. It also, another form of treatment is cognitive behavioral therapy or CBT, which can correct distorted thoughts and unhealthy eating patterns and behaviors. And also family-based treatment, which during this therapy, family members learn to help you regain healthy eating patterns and reach a healthy weight until you can do it on your own.
Now I'll be talking about the diagnostic changes from the DSM-4 to the DSM-5. First off, we have anorexia nervosa, and in the DSM-4, it was just classified as an eating disorder, but now it's also classified as a feeding and eating disorder. The criteria in the DSM-4 was that there was intense fear of gaining weight or becoming obese, even though underweight, and they changed the wording in the DSM-5 to the intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain. There were also changes for the types. In the restricting type in the DSM-4, it had to be within the current episode. They have not regularly engaged in binge eating or purging. And now in the DSM-5, it has to be during the last 3 months. And then in the binge eating purging type, it has to be within the current episode, has not regularly engaged in binge eating or purging. And in the DSM-5, it has to be within the last 3 months. So one thing that stayed the same from the DSM-4 to the DSM-5 was that it was the disturbed by one's body weight or shape, self-worth influenced by body weight or shape, or persistent lack of recognition of seriousness of low body weight. Another thing that was dropped from the DSM-4 to the DSM-5, Amelia kind of talked about this, in menstruating females, absence of at least 3 consecutive non-synthetically induced menstrual cycles. And then remission was added to the DSM-5. In partial remission, after full criteria met, low body weight has not been met for a sustained period, but at least one of the 2 following criteria is still met. The first one is the intense fear of gaining weight or becoming obese, or behavior that interferes with weight gain, and the second being disturbed by weight or shape. And in full remission, after full criteria met, none of the criteria met for a sustained period of time. And then for bulimia nervosa, same thing as anorexia nervosa from the DSM-4 to the DSM-5, they added feeding and eating disorders. And in the DSM-4, the binge eating and inappropriate compensatory behaviors occur on average at least twice a week for 3 months. And in the DSM-5, binge eating and inappropriate compensatory behaviors occur on average at least once a week for 3 months.
And now I'll be going over some of the things that stayed the same in the characterization of bulimia nervosa in the DSM-4 to 5. For starters, one of the things that stayed the same is the characterization of bulimia nervosa as recurrent episodes of binge eating. And these involve eating an unusually large amount of food within a short period of time, typically within 2 hours, and feeling unable to stop or control the eating during that episode. And the second major part of this characterization that stayed the same is also the use of compensatory behaviors to prevent weight gain. And this often includes behaviors like self-induced vomiting, misuse of laxatives or diuretics, fasting, or excessive exercise. And another element that also did not change is the role of self-evaluation. In both versions, a person's sense of self-worth is often heavily influenced by body shape and weight. And finally, the DSM still specifies that these symptoms cannot occur exclusively during episodes of anorexia nervosa. This helps clinicians distinguish between the two disorders when symptoms overlap.
Okay, and just to continue what was added and dropped to the DSM-5, there was the purging type, which during the current episodes, the person is engaged in self-induced vomiting or the misuse of laxatives, diuretics, or anemias. And then there's also a non-purging type that was dropped. And this is during a current episode, the person uses inappropriate compensatory behaviors, and this could be fasting or excessive exercise, and they're not as regularly engaged in vomiting or the misuse of laxatives, diuretics, anemias. And then for what was added to the DSM-5, there is partial remission, which this is after some criteria has been met. Some but not all of the criteria has been met for a sustained period of time, and then full remission, which after the full criteria was previously met, none of the criteria was met for a sustained period of time. And then there also are different current severities that were added. So there's mild, which is an average of 1 to 3 episodes of inappropriate behaviors per week. Moderate, 4 to 7 episodes. Severe is 8 to 13 episodes, and extreme is around 14 or more episodes per week. And just to summarize all of the information we learned, it's important to know that DSM-5 has greater evidence-based criteria, clarity, recognition, or cultural factors, and more of a dimensional approach compared to previous editions, and that there is a reliance on categorical diagnosis, overdiagnosis. There are limited findings with biological markers, and also the potential for future revisions. I think that's really important. The current edition is also involved in, or it involves symptom duration, amount, and type. There's biological and a psychological emphasis with who qualifies for the diagnosis and also the impact of treatment. And with the pharmacological perspective that it takes, it's talking about what medications are used, how the medication targets biological or neurological symptoms. For a cognitive behavioral perspective, you're thinking about thoughts and behaviors, and also evidence for the effectiveness. And for more of a psychodynamic, well, there's also psychodynamic, humanistic, behavioral, different treatments, methods, and goals that are included in the DSM-5. And just to continue off that, focusing more on anorexia and bulimia, it includes we talked about different treatment approaches, including pharmacological, cognitive-based therapy, family-based treatment, psychodynamic, nutritional management. And it's important to know that the DSM-5 includes severity specifiers or it's based on the BMI for anorexia. And it also includes severity levels based on the frequency of the behaviors and the differentiation of the disorder. And then just overall, there's a broader inclusivity for diverse patients. There's an earlier and more accurate diagnosis now with the DSM-5. And lastly, there is evolving care that is being monitored during treatment. And these are our citations.